very good day to you. We are going to address our minds to the topic, prevention of mother to child transmission, PMTCT, of hepatitis B. I should say that many people all over the world have heard about HIV. Many people have known about COVID-19 now, SARS infection. Many people have heard about Ebola, but many people are not aware of hepatitis B infection. And the havoc it does continues silently. May I say this? If hepatitis B infection becomes a chronic one and is not detected in an individual, the havoc can continue that years later, decades later, the person might have what we call liver cirrhosis, in which the liver is scarred and will not be able to carry out its functions within the body. And ultimately, and when it cannot carry out its function in the body is in danger, because the liver is the powerhouse of the body. All structures, organs in the body are important, but the liver is the powerhouse. In everything we need is a place where a lot of metabolism takes place. And so when it is affected, it can be life-ending. It can be life-altering and life-ending for the person suffering from it. That is important. I've seen people who were not detected earlier until they got into their 30s and 40s and their lives were cut short prematurely because of development of primary liver cell carcinoma. That is the importance. That's why this topic is very, very important. Hepatitis B viral infection belongs to the Hepatnaviridae family. We have hepatitis A, B, C, D, E now, the hepatitides. Okay? Hepatitis B viral infection is one of the major infectious diseases of the liver worldwide, caused by small envelope double-stranded DNA, deoxyribonucleic acid virus. The incubation period ranges between 6 weeks and 6 months. And concerning its epidemiology, over 2 billion people have been infected by hepatitis B virus globally. Nigeria has a high prevalence, with over 18 million people being affected. That is, about 10.2% of Nigerians have hepatitis B. Many people do not know that they harbor it. And that's why when pregnant women present, they present with a golden opportunity to have them screened so that their infants, will be screened and treated accordingly so that their lives will not be cut short decades later. 10 to 20% of hepatitis surface antigen positive pregnant women transmit the virus to their neonates. And that's important. Oftentimes, it can be transmitted, later in life from blood, contaminated blood, etc., etc., through sexual intercourse. But then the vertical transmission is very, very important. So from studies, we have seen that 10 to 20% of hepatitis surface antigen positive women transfer the virus to their infants. 10 to 20%, that's high. That's high. How then do we prevent mother-to-child transmission of hepatitis B? I must say that initially, I've said the incubation period ranges from 6 weeks to 6 months. So you can have an acute phase. After resolution of acute hepatitis, 5 to 10% of adult patients and 90 to 95% of infected infants develop chronic infection. They will have forgotten that they had an acute phase, and the chronic phase will continue for decades. And of course, when the chronic phase continues, The sequelae of chronic hepatitis B infection will be liver cirrhosis, in which the liver, so to say, the architecture is disordered. The liver, all the parts that ought to be, they are damaged, and the liver will not be able to function as it ought to. So liver cirrhosis, so hardening, so to say, of the liver, and can shrink in size. And of course, all the metabolic functions it ought to carry out will not be able, and so there will be manifestations in the body. And of course, with chronic hepatitis B infection, if there is no intervention, hepatocellular carcinoma can also occur, which can be life-ending, life-terminating. What are the risk factors for transplacental transmission of hepatitis B? 1. Maternal hepatitis B envelope antigen positivity. We carry out tests in the laboratory, and if this antigen is positive, hepatitis B envelope antigen, if it is positive, so there is a risk factor for the transplacental transmission of HBV, hepatitis B viral infection. Secondly, if the hepatitis B envelope antigen titer is detected and it starts getting higher, is a risk factor for transplacental transmission of HBV. And the third one, if there is high hepatitis B viral DNA level, yes, it's also a risk factor. So these three risk factors are very, very important for the transmission, for the transplacental transmission of HBV, hepatitis B viral, from the mother to the fetus. Maternal hepatitis B envelope antigen positivity, hepatitis B envelope antigen titer, it is increasing, then high hepatitis B viral DNA levels. When it is high, yes, is a risk factor for the transmission from mother through the placenta to the fetus. Now, we now look at this algorithm for the management of hepatitis B viral infection in pregnancy. We should encourage our pregnant women, to book as early as possible when they are pregnant. But this is not what we see in our facilities. Many of our women, they come to book to register very late. Some will have even reached the third trimester. But as much as possible, we should encourage our women to book as early as possible for their own benefits and the benefits of their infants. So, when the woman reports for booking or to register at an antenatal clinic facility, we must screen her for hepatitis B surface antigen, HBsAg, and HIV antibodies. Yes, we screen them. So this day and age, we screen for all those: HIV, hepatitis B, and hepatitis C. We screen for all those. Then, if the woman is positive for hepatitis B surface antigen, we now go further to do complete hepatitis B viral screening, complete. And we have about all the following things I'm going to mention. You will need to screen for hepatitis B envelope antigen, anti-HB, hepatitis B E, anti-hepatitis B C antigen. Then we must screen for anti-hepatitis C virus. And we must also carry out abdominal ultrasound scanning. Now, this can tell us whether the architecture of the liver has been affected. Does the liver look as if it is hardened? Are there changes already occurring? So all this we must do. Then, of course, when a woman is positive for hepatitis surface antigen, we also screen the husband or the partner of that woman. We screen the husband as well, and we do serology tests even for the husband as well. And if the husband is positive, we refer accordingly to the gastroenterologist. All right. Well, back to the pregnant women, because it is important. While we are treating the woman, we are intervening concerning the woman, we should remember her husband too. And of course, if the woman had delivered before, other children that she had delivered before she reported at that index pregnancy should also be screened for hepatitis B. That is very, very important. Index testing. So, if all those tests I mentioned earlier, the envelope antigen, the anti-HBe antigen, anti-HBC are positive, we confirm that there is chronic hepatitis B disease. Then later, we now move forward to do hepatitis B DNA. As we should try as much as possible to have this done by the 24th week of gestation and not later than 28 weeks of gestation if booking was late. So by 24th to 28th week, we must have this DNA test done because it's very, very important. If the serum HBV DNA is greater than 200,000 copies, then we might need to treat the woman. We'll need to treat the woman with antiretroviral drugs like tenofovir or telbuvidine or lamivudine from 28 weeks gestation. And if she booked late, from 32 weeks if booking was late. So we encourage the women to book early. We confirm chronic hepatitis B infection, carrying out the panel tests. We call them panel tests. Envelope antigen, anti-HBe antigen, anti-HBC, okay, core antigen, and so on and so forth. Okay, core antigen, envelope antigen, we do the panel test. So if all these are positive, it will confirm that the woman has a chronic hepatitis B disease. And later, we now do the DNA assay. And if the copies of the DNA are greater than HBV DNA are greater than 200,000 copies. Now, we now treat the woman with tenofovir, telbuvidine, or lamivudine from 28 weeks gestation continuously, from that gestational age. But we discontinue the treatment immediately after birth with the ARVs. It's not a lifelong thing. If the woman has only hepatitis B viral infection, but let's say the woman has a comorbidity of HIV. HIV treatment with ARV is lifelong. But for hepatitis to prevent transmission, vertical transmission from the mother to the fetus, it is only from that point, from about 28 weeks till delivery. Made after delivery, after birth, we discontinue the ARV for the mother, and the mother is referred to the gastroenterologist. Now, the product of the pregnancy, the infant or the infants, will now have hepatitis B immunoglobulin within 12 hours of birth, followed by hepatitis B vaccination, same day, or latest within 1 week of delivery. So that's how the transmission from mother to the fetus or to the infant is prevented. And of course, after we test the baby for hepatitis surface antigen and anti-HB at the age of 9 months. Okay, so that's it. So if we follow this algorithm, we now know that will prevent transmission from the mother to the infant, and we'll be able to start breeding HBV-free, chronic hepatitis B infection generations. And we can see, all right, I've mentioned earlier, if it were negative, okay, we screen for anti-HBs, and if it is anti-HBs is negative, we take no further action if anti-HBs, okay. Then let's take that again. Hepatitis surface antigen negative, the woman who has come, okay, let's start from antenatal clinic booking again. We'll take for the woman who is positive, and we followed it from pregnancy till delivery, till 9 months of the infant being delivered, in that the baby, the product of that pregnancy, will be tested for hepatitis surface antigen and anti-HBs at 9 months of gestation, so that we know whether the prevention, the intervention we carried out for prevention had been effective or not. So that if it's not effective, now the infant will be focused upon. But if the pregnant woman who came for screening, for booking at the antenatal clinic, were to be hepatitis surface antigen negative, what else follows? We screen for anti-HBs. Okay? If anti-HBs is negative, we take no further action. Okay? Then, but if anti-HBs is positive, we administer hepatitis B vaccine to parents. Okay? And baby gets hepatitis B vaccine at birth. No HBIG. Why? I mentioned that so as to focus on the infant of the woman who is not hepatitis surface antigen negative. Okay? So we administer hepatitis B vaccine to the parents. Yes, because they are negative and they could still get infection from elsewhere. Okay? So we use the opportunity to administer hepatitis B vaccine to the parents, and the baby gets hepatitis vaccine at birth. There will not be any hepatitis B immunoglobulin, which is different from the baby, for the infant whose mother was positive for hepatitis surface antigen. So the infant, yes, here, the infant of the mother whose mother was hepatitis surface antigen negative, the mother will have administered to her hepatitis B vaccine, and the father too. And the baby gets hepatitis B vaccine at birth, but will not have any hepatitis B immunoglobulin. Unlike the baby born to a mother who is hepatitis surface antigen positive, that one will have the vaccine as well as hepatitis B immunoglobulin within 12 hours of birth. So that's the distinction. Okay? We have that's the distinction between the two. And of course, if while the woman comes for screening, she's HIV positive, of course, we refer to for PMTCT and of the HIV program. Both of them, HIV and hepatitis B, can be managed concomitantly. And of course, if the woman were to be HIV positive and she's already on ARVs for HIV, she will continue the ARVs for life. Unlike in women, if it is only hepatitis surface antigen that she's positive for, we give the ARVs that I mentioned earlier, tenofovir, telbuvudine or lamivudine, just from the 28th week of gestation till delivery. Thereafter, we stop, and we give such a baby immunoglobulin as well. So it is very, very important. So that's why when this algorithm is properly followed, I believe we start having breeding hepatitis B surface antigen free negative individuals. Because like I said, if the chronic infection continues, it can be life altering or ending decades in life. And the transmission will continue from one person to the other. So that is the prevention, and prevention is always better. What are some of the drawbacks? The vaccine is expensive. The immunoglobulin for the infants, very expensive. So anything we can do, and that's why when the women come and they are positive, we prepare them ahead to start saving or sourcing for funds, because it will be so painful that the woman comes and later she says she cannot afford, because these medications are very expensive. They are very expensive in our own environment. So, and that's why immediately we start getting the panel results being positive, we start sensitizing them so as to start preparing funds, to source for funds, so as to get these medications, hepatitis B immunoglobulin, so that the child can be given within 12 hours of delivery. Thank you.